I got a lot of questions coming in through the chat here today from our presenters, folks, and they're still going to come through as we go. I want to encourage the folks in our audience to know at any point that you decide you want to ask another additional question, just go ahead and put it in that Q&A icon chat and ask us, and we'll try to get to as many of these as we can, given the time that we have today. So keep on asking. I believe this first question is going to be for you, Myque. It's actually kind of a two-part question, if that sounds good. Let me go ahead and toss this over to you. The first question, Myque, was what are some care gaps that you and your team would like to address? And then on the heels of that question, what is something you dream of being able to do but currently cannot? So I'll let you run. Myque smiles. He said, how much time do you have? I'll let you run wild with those.
Yeah, thanks, Paul. Wow, big questions there. I think one of the biggest gaps right now, I can think about two. The first one is the inability to really have people with lived experience be able to work within our team in a medical setting within the jails. I mean, that would be huge because there's an inherent issue as it relates to the background check process. You know, it's extremely rigorous, and I think limits what we could do. And I mean, I can say that coming from where I come from, it means so much seeing somebody who looks like you, who's been where you are, who's sat where you sit, and hear things from them. Those types of people is massive, and that they turn their lives around and that they're back in service and trying to get other people to do the same. So that's a pretty big gap that hopefully, you know, as we continue to deal with the crises that we see with fentanyl, substance use disorder, and more, that is an issue that maybe can be less and less of a thing. The other thing that I also see that I know there's a lot of work going on right now is the transition component of getting people from the jails into getting a primary care provider, getting them assigned and getting the consistency of you know, visits. The cost of SUD long-term medication is exceptionally high. You know, when you're talking about Sublocade, you know, funding is a big problem. I know Brixadi is a new medication that's a lot cheaper, you know, but it's still rather expensive. So things like that, I think, can really we could do a better job of as an entire system, as a country, to afford people the opportunity to actually get the treatment when they're ready for the treatment and to turn their lives around. So I think that's hopefully answers some of, you know, your first couple of questions there. Paul, I cannot remember the second question.
It was kind of a daydreaming question or a wish list question. Is there anything you dream of being able to do that we currently can't?
Yeah, you know, it's interesting you say that because I think, you know, when you hear Melanie, when you hear all these presenters, I think there's people that are doing such an excellent job of providing jail healthcare. And I think because of that, it's like a catch-22, because you're so good, we'll keep it as it is. The system we know is inherently broken. I think when you look at what Europe is doing, I mean, I think we could completely redo the jail and prison system in a way that is absolutely revolutionary. And we don't even have to reinvent the wheel. All we have to do is, you know, go across the pond, you know, maybe have 2 or 3 people do a pretty comprehensive assessment into all, you know, those kind of systems, what it would take to come and implement that, you know, in a local setting here within the US, then that other people then can replicate. So when you talk about pie in the sky, that's something that I think about often. And you know, maybe we'll get there one day, but I just hope and wish that we will get there sooner than later, because a lot of people that adults and youth in custody shouldn't even be in custody. I think it's just because the system is what it is. It makes it so difficult for people to have the resources that they need in the community, and we become a default primary care provider, a default dentist, a default behavioral health clinician, for a lot of the adults and youth in custody, which is really a tough place. So I hope that answers the questions.
It does. It does. I'm just curious. Is like, can you share an example of something that you've seen that has been implemented in Europe that you're like, wow, that is so different than what we do here? That would be.
I think just the general setting. Even when I think about our own setting within Multnomah County jails, it's not built with healthcare in mind, or in a place that is rehabilitative. When you're thinking about the aid and assist docket, and I know that was brought up a little bit with the folks who have severe and persistent mental illnesses, jail isn't a therapeutic environment. And in Europe, they have places where people can actually go, and it's more of a dormitory style setting where they can be humans and not put in, small spaces with very limited out of cell time. And it's a humanization of disease, especially behavioral health diseases. I don't think our country has done the best job of that. We could absolutely do a better job of. So I think just access to simple amenities, your sweater, a phone, books in your space, just things that are simple in the way that they set them up to make them feel like people. It's really incredible. But again, this is anecdotal from what I've heard from other people that have seen this. It would be nice to have people that work within these spaces go there, engage with the staff, engage with the systems, be able to do a comprehensive study, and then bring that information back and find ways with legislators and local authorities to really revolutionize the incarceration system that is within our country. I don't know, it seems high in the sky, like I said, but I think that's something that would be quite amazing, in my opinion.
Well, I, for one, always like to believe that change is always possible. So I think that it's, and especially when people are willing to point out how things can be different, I think that's one of the greatest first steps, and being aspirational. I mean, that's certainly how we're aligned here at CareOregon, for sure, is believing that things can change. So I think that's fantastic. I think this next question, Melanie, I think this came through during your section here, but anybody I think can riff off this. But this one person that wanted to know, is there a specific timeline for when the OHP gets turned off when someone's incarcerated in jail?
So every jail is different on how the information gets transferred to OHP that says an individual is incarcerated and their OHP is suspended. So that could be the day after they enter the facility, and for some people it could be 30 or 90 days later, depending on how long they stay. The timing is pretty inconsistent. In the correctional setting, in the jail itself, we don't bill for services that we provide to individuals. Some jails may have a fee that an individual has to pay for over-the-counter medication that can be ordered on commissary, which is how they get those things if it doesn't come from the medical department, or for excessive or overuse of the healthcare system, they can be charged some fees in some jails. But for the most part, we don't bill for services. Because of that, we don't really know when the OHP turns back on. Occasionally, we'll find out from some of our external service providers, our OBGYNs and neurology and cardiology offices, who will run their OHP. If it's active, they'll bill it. If it's not active, then we pay it. However, that payment model is already established. We all have established payment models for our adults in custody when they're outside of our facility. And then the reinstatement process. So there is a form that I mentioned, a 7100 form for all individuals who had active OHP prior to entering a correctional facility. We submit that 4100 form the day they release. OHP gets it, processes it, and then the client's insurance is turned back on. There are a couple of nuances that I will let Cassi talk to, but for the most part, that is the process.
Great. Thank you, Melanie. Thank you. And I'm not sure whose presentation was up when this question came through. I think it might have been Hannah's, but it could have been anyone's on here because this is about mid scope. Someone made a comment that they identified themselves as being a traditional health worker from rural Curry County. And the question was, is it a law that every jail has a medical department? I know we talked a lot in various presentations about, hey, things are different from one institution to the other, right? But they want to know, is it a law or a requirement there has to be a medical environment, and that they provide things such as detox and medication management? Because, you know, I think a lot of our attendees are sharing this morning that they had no idea that the jails had this.
I'll speak to that just a little bit. It is not a law. There is no law in the state of Oregon that requires a correctional facility to provide on-site medical services. However, there are specific standards set by both the state and the Oregon State Sheriff's Association for how an individual in custody is managed while they're in custody. And those standards include things like medical care, which includes care for detoxification and mental health interactions is what I'll call it. It includes how and when we change their uniforms out, how and when they get a change of clothes, because they don't get their regular clothes when they stay in the jail. They get jail issued clothes. It includes, how many times we expect an individual to shower per week. It includes their meal services, their hygiene products, whether, how and when and what they can grieve as part of the incarceration process. But there is nothing that mandates that healthcare is provided by a healthcare professional inside the correctional facility. And within the state, there have been several discussions over the last couple of years about maybe moving to an ORS or an Oregon revised statute or a rule that does mandate that. The problem is that, as I said in my presentation, medical care is not provided in all facilities. And Curry County, I'm pretty sure your jail does not have medical services or long-term medical services. And part of the problem with mandating it across the state, you can mandate it if you want to, but where is the funding for those services going to come from?
Mm-hmm.
If you live in a county with a very, very small tax base and you are only able to pull in an appropriate amount of property taxes or other taxes that are charged to cover the basic services of your jail, the facility, the officers to provide safety, but then there's nothing left to provide medical care, you are going to choose your officers, your safety, your food, and your clothing before you choose the medical care. And in those facilities, it would be a disservice to the community to require those things, because either the community is going to assume the cost difference, or something else in the jail is going to get cut. And sometimes we're talking about basic needs services, and that would be disproportional to many, many counties in the state. So I don't think that will ever happen. If there was a way to make sure that, one, the funding was there to fund a state mandate for healthcare services, then that would be a different conversation to have. But I don't know if we're there yet.
Interesting. That's a really good point. And then a lot of questions have kind of echoed along this lines too. It's just like, because it doesn't sound like there's really like a consistent standard of care across the state, right? I mean, things like staffing ratios, adequate staffing per inmate, right? I mean, those things are so in flux and variable.
Yeah, there are not, Myque may be able to speak a little bit more about staffing ratios, particularly for Multnomah County, because they are an incorporated healthcare services where their correctional healthcare and their outside public health care are kind of under the same umbrella, which means their nurses are also protected under the union for the healthcare workers. Many of us don't have that opportunity, so we don't have set patient ratios, right? I said there were 330 people in here today. There's one mental health professional, one nurse practitioner for mental health, one nurse practitioner for medical. There are 2 LPNs and 2 RNs, and that's it. And they take care of 330 something people. And when you think about that from a hospital setting or a office clinic setting, that seems absolutely ridiculous. And I'm not going to say it's not, but I will say that for the most part in a correctional facility, the majority of people that are in our care, minus our acute psychosis, minus those, are able to care for themselves in some form of fashion on their own. They're able to advocate for themselves. They're able to advocate for their medical needs, their mental health needs, their basic needs, and they're able to provide those needs on their own. So managing that population with a smaller number of nurses is not unheard of across the country. So.
Wow. Mike, did you want to add to that?
Yeah, if I may add just a couple of things. Melanie spoke super clear about that. I think one of the issues we run into when it comes to jail care and laws is it's super broad. You know, if you look at the Constitution, you know, the 8th Amendment simply says, you know, it bans cruel and unusual punishment. And every state in the country can basically say, well, you know, basic health care is all that's required to be provided, you know, and it's something that's been in the courts for you know, off and on. And so as long as they're providing something basic and not violating the 8th Amendment via cruel and unusual punishment, then it's upon each state to then implement a lot more stringent requirements, which is typically, you know, not the case as, you know, it relates especially to rural settings that have very small populations. It's really, really difficult to manage. You know, and as Melanie said, you know, for us in Multnomah County and folks that jails that are accredited through like NCCHC, for example, we have to have a minimum staffing model, minimum number of nurses per shift, 24 hours a day, 7 days a week. So come rain, snow, sleet, and because we are part of the health department, our nurses are indeed under the Oregon Nurses Association Union, and where we have a contract with them that dictates, you know, shift times. You know, we're able to mandate nurses to the next shift to be able to ensure that we're meeting minimum number of staffing, you know, so there's a lot of things that we have in place. But again, we recognize we're a really big system here in Multnomah County, and that doesn't apply across the board.
One other thing here, it's so funny to see the questions that come through, right? Because there's a lot of common themes in here, and I want to make sure to point this one thing out. So many of these questions begin before they get to their question, they begin with addressing you all as presenters, right? I want to thank each and every one of them for their service. I was blown away and had no idea that these services are available behind the scenes. Very grateful for this. I mean, you see a lot of, you know, a lot of the questions are prefaced by that from folks just really relating to this content today and really being grateful for it, and a lot of eyes being opened that people just don't have the realization of what goes on. Couple questions here. This person, I think that they must do some mental health work as staff in jail, and they're wondering, are there any supervision or consulting groups? I think this came up during your session, Hannah. Any kind of supervisory or consulting groups for mental health jail staff that you might be able to share?
Well, I think that's a great question and really important. I don't know. On the jail side, I don't know. I think that would be a really certainly important thing to have access to. Perhaps Melanie or Myque know a little bit more about the intricacies of what happens in the institutions. However, I will say, you know, in the community in practice, supervision is a must, right? And supervision is what is going to help us not only consult, but to see, just Paul, as you just said, these broader themes of what we're seeing towards larger system change. And so what's happening in the jail is not a vacuum. It's not isolated. These are broad system social patterns. And as Myque was sharing about his dream for, changing the system, that's what we're doing. We're changing the system and also working with the folks who are directly impacted right now. And so supervision is really the key to supporting providers, preventing burnout, but also kind of tracing those patterns and themes so that we can change our world.
Well, it sounds like there's definitely an appetite for groups like that for to provide guidance across for folks who are in there. So we'll definitely have to see what we can do to explore that more. Similar question. I think this is probably somebody who's very inspired by what you all shared here today, but they were curious, are there any kind of volunteer services available that any of you know about that folks can be involved in?
I don't want to hog all the time.
You go first, though. Nothing wrong with that, Melanie. Come on.
So the answer to that is yes. And it really depends on each of the individual jail facilities, what the volunteer opportunities are available in the facility. So for instance, Clackamas County, we do a NAMI kind of group facilitated meeting for our clients several days a week. We rotate housing areas. We do GED education with Clackamas Community Services. We do some parenting and domestic violence classes. It just depends on what is the need within your facility and who is available to do those services. There is a background check process that each volunteer must go through. And for some people, if you've never been through this type of background, it can seem pretty intrusive, right? We're going to ask you things about your personal histories, your financial histories, things you may not want to disclose, but if you don't disclose, we're not going to let you in our facility. So it just depends. Most of us have one person that manages volunteer opportunities. So if you're interested, you can reach out to any jail and ask for their volunteer coordinator. And that person can give you the information about what programs are available or what might be needed if your particular area of interest is something that we need in our facilities.
That's great. I mentioned one thing too, that my brief exposure to being inside of a correctional facility that opened my eyes in a lot of ways. For years, I've been involved with like the Toastmasters organization, like a public speaking organization, right? And as part of my journey there, I started working helping mentoring clubs for a little while, and it just through random luck, I got assigned to work with the Toastmasters Club at Columbia River Correctional Institution, right? And I was like, I had no idea that there were Toastmasters clubs, that were public speaking clubs in there, and I had to go through the volunteer authorization thing that Melanie is describing, right, where the background checks and everything, because they have to be really careful who gets in. And what I saw was just amazing. And just unbelievable to get to see folks who are in this environment getting a chance to, I think in a lot of situations for the first time, express themselves in front of a group and be able to articulate what they'd gone through. You hear a lot of like origin stories. How did I get here? How did this happen to me? But you just see a real empowerment with that. And from what I've heard, people who have gotten involved with that program, the recidivism rate is a lot lower. And I don't know if there's a direct connection, but I think just in terms of, I think we can all identify that when you're able to express what you're feeling, and it's like with motivational interviewing, right? When you're able to like identify what your thoughts are, it's powerful, and it can be really liberating in a lot of ways. I'm trying to be mindful of the time here, because I know time's getting away from us really, quickly this morning, but I wanted to circle back with Cassi if I could, just because I don't know, Cassi, that enough folks are getting a sense of how we at CareOregon and the plan are getting involved here. and what we're doing. And is there anything you want to make sure that you express about coverage, what's available, our relationship with institutions? I think you should have a chance to just go nuts and say whatever you want to.
Yes, I am absolutely happy to. And I did see quite a few questions come in to us just about logistics of coverage. So I'm happy to dive into that piece. So I think it's important to understand that the reason currently that folks' coverage is suspended during incarceration is really the rules that exist and govern Medicaid and Medicare coverage are the ones that dictate that for us. And so at current, as Melanie and Myque talked about, folks are suspended upon their entry into a carceral setting. And then, of course, we work together to do a lot of stuff to hopefully get them reinstated as quickly as possible once they release. But we are not able to remain the active coverage during those periods of time. I will say that a little bit to what Paul was saying and looking into the future is that we may see some changes to this. We hope to maybe see some changes to this in the next couple years. And I think Myque started to allude to that during his presentation this morning. So we have a CMS engages, a Center for Medicaid and Medicare Services engages in what a process known as an 1115 waiver, where they apply for different types of new or innovative ways to think about coverage and care. And one currently that they are looking at is covering folks, allowing folks coverage to be reinstated sooner than at the point of release. So this would also look like adding services to be available across the board for folks in our state in that last 90 days of their incarceration. Again, because we know so clearly in the research that prepping for those transitions and having solid transitions in and out really does make a huge difference for folks. So that's something that we'll be watching at CareOregon. It's something that we are already, as Myque talked about, we have a lot of conversations around with our local metro region to talk about what that could look like and how we might start to work towards that, as we really do see that aligning with what we would love to see regardless. So as Myque mentioned, we do a lot here locally to bring our 3 counties together, to have space to talk about what's going on, to help develop new programs and new ways of caring for our members who do transition through carceral settings. So yeah, so we have that coming. So I think that's important for folks to understand and be paying attention to and looking out for if you do have an interest in this population.
Thank you.
Yeah, anytime.
And then this kind of, I think, follows right along with what you were saying. Is OHP turned off because the jail becomes the payer in some of those circumstances? Or would it be possible for it to stay turned on but become a secondary payer? Is that I think they're hoping that that would provide more continuity in transitions. Does it seem relevant?
I mean, I think it sounds like a great idea, and unfortunately is not something that we are able to do at this point in time. So that is true that the payer becomes essentially the county or the jail system. So, or if we're talking about a prison system, right, the state becomes the payer of those services in that time of incarceration. So we are not, again, it kind of comes back to these rules that govern how we operate. We are not able currently to remain on as the secondary payer. But again, this is like, I would say in the last 2 to 3 years, we have seen a lot of changes and attempts at doing this across the US. And so I think that we will continue to see, just like doing some of my own forecasting, we will probably continue to see some changes and modifications to how we care for folks in custody and how we cover those services, I think in the 5 years probably forthcoming. And we have, I think that there's definitely a lot of opportunity of how to think about still helping transition folks regardless of payer. So we talk a lot about this here at CareOregon, and we do a lot of work thinking about how to still support our folks, knowing that they are suspended, but they're going to return to our plan once they release. And like Hannah said, 98% of these folks are coming back to our community. So I still think there's a lot of opportunity, even without the coverage, to come up with creative ideas and think about how to create that continuity within your systems.
Wow. I'm just looking at the time, and I think I know how busy all of you presenters are in your lives and the work that you do. So I think I need to be mindful and let you get back to it today. And we'll close this session out with some housekeeping for our attendees here for the audience. But before we let you all go, I just, again, on behalf of all of us at CareOregon and all of our attendees today, I just want to thank you all for the incredible work that you're doing. I mean, you literally are changing lives with the work that you're doing and making things so much more hopeful and optimistic for so many individuals. So we just want to be able to make sure that we express our gratitude to you and for the work you're doing and for being here today. A lot of people have had their eyes open today and finding out about things they had no idea about. And it's wonderful to see the hope that's being brought to light because of all this. Thank you. For our attendees in the audience, I just want to reiterate a couple things for you, and we'll close this session out today. Thank you for being so engaged and for being so interactive with the chat today and asking all these great questions. Again, we'll be sending out copies of all of the slide decks today, so you're going to get a chance to see that real quickly. I just want to show you a couple other things in terms of housekeeping things, and we'll let you out of here real quickly. Again, a reminder. We have sessions going up right until the beginning of summer here today. We have one in May on Tuesday, the 21st, on SUD's impact on youth, and an unusual and new one regarding the importance of integration for primary care to get more involved with referrals for oral health. We have learned a lot about this, and if that sounds like something where your reaction is, but that's not my gig, I'm primary care, why should I be involved in that? Then you really need to tune into this particular session, because I think you're going to have your minds blown by what we're learning. Pretty great stuff coming from both of these sessions, so be sure to enroll on these. All these sessions end up being recorded on video, just like the one that you have experienced today, and it'll be posted in the coming days and weeks on our primary care meds ed webpage. You'll have links to this in the slides that we send out, so you can access that and see the videos and share them with your friends and colleagues in the future. No passwords or IDs are required. In closing, I just want to thank everyone for coming today and remind you to check your emails later this afternoon. I'll be sending out a very brief attendee self-assessment and survey of the content you saw today around our learning objectives. And we use that to go ahead and log your attendance and make sure that you get your credit for attending, so you have your CME hours appropriately logged. And that's it for all of us here at Meds Ed and CareOregon today. Again, I just want to thank our presenters for being so generous and open with their content. I think this is incredible work. I really want to thank everyone for helping also to dispel so much of the stigma around this topic that makes things so difficult to overcome for these people who just are trying to reintegrate back into the world again. And it's just a reminder that we all have so much in common, and that we should be grateful for the hard work of people who are willing to change things and provide hope. So we'll see you here again next month for SUD and youth. And thank you all for showing up today and for giving us your attention. We so appreciate you and all the work that you do. Take care and be well. Thank you.